Okay, so what is coming around first are two handouts that look like each other. So you're going to get confused, okay? They're both pink, and one says record form, and the other one says remedial activities, okay? Two forms for the quick neurological screening, okay? So we got two coming around. One says quick neurological screening test 3 record form. You'll know you have it because the back has shapes on it. Okay? I hope we have enough. The second one says remedial activities. Okay? That side of the room I don't think has it. Okay?
Yeah.
Alright.
Did you get them?
Does everybody have for themselves and their friends the two forms? Raise your hand if you don't. Okay, good. Alright. I am not really going to talk about the remedial activities form, but I'm going to tell you what it is. So right on the top of this. Okay, so you have the quick neurological screening and you get your results and then you're like, now what? So this is a helpful handout. If not now with your clients, more so in pediatrics. So save this for when you go to your peds field work next summer. You guys will be like, I don't know what to do with these kids. And it'll be like, oh, if they have a fine motor problem, here's some things to do. And so they give you activities based on each subtest and its score, like if somebody does badly in a test. So in some way, if you're having a hard time making sense of what these little subtests are about, this would help you to apply it. So this is useful for you making sense of what the test means and how it applies to intervention, okay? And this is not an intervention class, but I thought this would be helpful for you all, okay? We good with that? All right, so we'll put the remedial form away or just put it aside for now. So let's kind of first go over the cranial nerve exam, okay? And the cranial nerve exam, let's see if we can put this on. The cranial nerve exam, right? We have the 12 cranial nerves, and really you all will not really be doing a whole cranial nerve exam, okay? Are we on tape now? Mm-hmm. Good. Okay, so, but you will read it in the medical record, okay? So, let me just tell you how a physician goes through a cranial nerve exam, okay? So, what is the first cranial nerve? Olfactory, right? And how might a doctor or you check if that nerve is working?
You get a
scent under the nose. Usually in an outpatient neurology, they don't even check that. They just say, can you smell, Mrs. Shotwell? Yes, I'm fine. Right? Little old lady Shotwell's bologna could be moldy in the refrigerator and I'm eating it and not knowing it because I don't smell, right? But I could be a confused old lady and tell the neurologist, yes, it's fine, right? So I'm not telling you to check it, but don't assume because somebody says it's okay that it's okay. Because usually if somebody's got particularly diabetic neuropathy and their nerve conduction isn't working too well, their dysfunction has been going downhill over the last 20 years. So they don't really notice that it's absent because they've gradually adjusted to it, right? Hopefully, little old lady shot whale has her vision yet and she can see the mold on the food that she's eating. Okay? So that's the implication of the olfactory nerve not working is I don't smell bad food. And that is more common than we want it to be, particularly with elderly folk. Okay? The other reason that not being able to smell, what's another critical reason not being able to smell would be a problem?
Gas leak.
Gas leak, it affects taste, and fire, or smoke, right? So if there's a fire in your house, you're in the sleep, like I know, my sense of smell is like actually overactive, okay? So if you all are wearing perfume, I might go, I can't concentrate. Please sit over there today. And it really depends on, I guess, where my body is at biochemically. So the other day, one of the kids at home on the stove, you know, like how something's stuck down in the eye. And I'm like, I'm down 2 floors down. And I'm like, what's burning? I'm like a crazy woman. And I come up and, you know, my daughter's sitting in the kitchen with something on the stove. I'm like, do you not smell this? She's like, what's wrong? You know? So people can have overactive nerves too, okay? Mine is, and it might not be that my nerve is overactive, but the area where smell is perceived is over-responsive, okay? Yeah.
Do you have to say that with like older people, if they lose their taste, is that usually why they don't have an appetite?
Okay, so losing taste could be the smell, but could also be the glossopharyngeal, or, you know, probably. But part of it is why they don't have an appetite, or while all of a sudden grandma starts putting Tabasco sauce on everything. You're like, grandma used to hate spicy food, and now she's eating Mexican food all the time. What's up with that? Or grandma only eats sugar stuff, and she never used to have a sweet tooth, right? And your families will tell you that taste will change. And so, to me, that basically it's about education for people to say, you know what, that's pretty normal. That's, so we need to maybe change what diet is available, what's healthy. So if we have a sweet tooth, maybe we would have more fresh fruits and vegetables than, or not vegetables, because not many of them are that sweet, but maybe more fruits, like, who's into the cotton candy grapes?
Oh, those are amazing.
Oh my gosh, okay. Who needs candy anymore? Cotton, they taste like cotton candy. It's like probably, you know, genetically engineered, but
Is it like a...
and you feel better that you're eating grapes, you know.
It's
It's
not like a
like,
grapple thing where like it's an apple that's like artificially flavored like a grape.
No.
no.
It's like-
It's probably genetically something, but they're good. Try it. Cotton candy grapes, but so that might be an alternative if grandma only wants to eat sweets. We don't have tons of candy in the house, but we keep fruits that will meet that palatal need. Is that a word? Palatal? Anyway, okay, so we okay for olfactory? Tested verbally, or we might, if we were really testing it, maybe we have a couple extracts. We stick a cotton swab in an extract of peppermint, lemon, pleasant things, vanilla. Wave it under somebody's nose. You could ask them, what is it? Now that's discriminatory sensation, okay? Rather than just detection. If it was just detection, you wave it under their nose and go, see if there's a response. Eye opening, you know, their mouth might start moving. Like if someone's in a coma, you would see if you wave some different scent, they start going like that. when they're in a coma. Okay? All right. Olfactory, second nerve. What's 2? Optic. So the optic nerve is, are they seeing? Okay? So the way we would check it is, like I'd say, what does that sign across the room say? Bathroom. Okay? Typically, I'm not going to ask an exit sign because people know what that says just by where it is. So they could fake you out, not have visual acuity. So the eye chart would be one way. The other way is using a flashlight and sticking a light in the eye, and you can check a bunch of cranial nerves at once. Okay? So what other nerves deal with the eye? Okay? Oculomotor, trochlear, and abducens, and the optic. So we got 4 cranial nerves that deal with the eye. Okay? So typically what's going to happen is we are going to check the cranial nerves in, like we'll do sort of an H pattern with the flashlight, or we will take, let's see who has a pencil in the room. Oh, like Josh's pencil is, I like his better because his, hi absent people, his has this silver. So I like a number 2 pencil, and I'll say, Marissa, look at me, don't move your head, and I might like put my hand on her chin, and I'll say, follow this. Okay, so right now I'm doing abducens. Go up and down, that's oculomotor. Now go in towards your nose. When you cross your eyes, that's trochlear. Okay? So we've checked 3, 4, and 6 by just doing the crisscross applesauce and to the nose. Okay? The way we check 1, okay, is kind of 1 and 3. So the pupil opening and closing in part is 1 and in part is 3. Okay?
1 and 3 or 2 and 3?
I'm sorry, 2 and 3. Thank you, love. Okay. So on this one, I say, just look at the light, okay? And what I'm looking for is the pupils should constrict. Okay? And if they don't, we got a problem. Now, be aware, you can have this back, be aware that people might be on certain drugs that make their pupils dilated. So, just be aware of that, okay? Okay, so we got 1, 2, 3, 4, we didn't get 5 yet, and 6, okay? Just by doing the little H pattern or crisscross, right? And then it's called convergence, where you bring your finger to your nose like you're crossing your eyes. That's in and toward the middle is trochlear. So in and down is trochlear. Okay, now the 5th cranial nerve, trigeminal, is both, is that the one that's just sensory? Some say
It's both.
marry money, but, okay, there we go.
Facial sensation.
Yeah, so it's like facial sensation, okay, and then some movement, but it's kind of cool that we have redundancy in facial stuff, which is why our face can be so expressive, right? We have the 7th cranial nerve that does like eyebrow lifting and some facial muscles, but the 5th cranial nerve also does some of that. So the doctor will say, puff your cheeks out, and they're looking for 5th cranial nerve, right? They'll say, raise your eyebrow, they're looking for 7th cranial nerve. So that's the way the doctor will just do one thing to check it. And then they'll say, when I touch you, say touch to check the sensation. A cranial nerve exam takes a physician about 2 minutes. Okay? Then, okay, so that's 5 and 7. So we're all the way to 7 now, right? Now we got 8, okay? And they will check 8 and 10 together. And what they will do is they'll stick a tongue depressor down your throat, and they'll see if you have a gag reflex. And if you move like your pharynx to close it off, when I stick the tongue depressor down and you gag, then I've checked 8 for the pharyngeal response.
Is that 8 is vestibular control?
I'm sorry,
So 9 is altogether?
9. Thank you. You're my good checker here. 9 is, they'll check it 9 and 10. 10, the vagus nerve. Vagus does a lot. It does like your heart rate and all that, but it's also the gag reflex. So that's why they double dip there and just stick a tongue depressor down your throat. And that takes 2 seconds. Okay. Vestibulocochlear is interesting. They will just like snap on the side of your ear and say, close your eyes, where do you hear this? And then you just point left or right. It's easy. So lots of times if they're doing a quick cranial nerve check, they will just do the auditory part or the cochlear part of that 8th cranial nerve. But if they're checking vestibular, they will say, usually after they've done everything sitting, they'll say, stand up, Mary, now close your eyes. And then if I lose my balance or have significant postural sway, they'll say vestibular problem. Make sense? So that's the 8th cranial nerve. 9, glossopharyngeal, gag stuff. 9 also overlaps with 12, right?
Hypoglossal.
Hypoglossal. And what they will have you do is stick your tongue out. Mary, stick your tongue out. Move it to the side. Left, right, and up, down. Just like you do with the eyes, you do that with the tongue, which really is a little more of hypoglossal than it is glossopharyngeal, but there's some overlap there. And it's just amazing that this wonderful overlap was built into us by our Maker. Because if one cranial nerve is impaired, the other cranial nerve can do some of those functions. So again, even if optic is impaired, oculomotor can do some of that pupil dilation and opening, or dilation and constriction. Okay?
And you said they test that by having you stick your tongue out and move it around?
Uh-huh. Stick your tongue out. It's easy. See, see how quick it is? Yeah.
I have a question about the pupillary, the tracking.
Yes.
Left and right is oculomotor.
Well, left and right is more abducens, right? Because your eyes go to the side with abducens, right?
Okay.
Up, down is more oculomotor.
Okay.
And then in and down toward the nose is trochlear. It's good you asked that because I'm sure somebody else had that question.
So the abducens would be like more of like your peripheral vision.
Yeah, Yeah? We good? Alright, we'll do it in a second. But I wanted you to have the big picture of the cranial nerves. Okay? Typically, the other thing, the doctor has already checked your lower extremity like strength. They'll have you lay on the table and they'll say, push against my hand on the bottom of your feet. And the reason they're doing that is they're making sure that your feet know where they are in space or have some proprioception before they check your vestibular function. Because when I have you stand up to do balance, right, it's more than what's going on in my inner ear. It's what's going on in my ankles as well, right? So my ankles if I have weak ankles, I fall, right? So the doc wouldn't know, did Mary fall because her ankle muscles are weak or her proprioceptors are weak, or did she fall because she doesn't know where her body is in space? Does that make sense? Okay? All right, so let's come up here close, okay? How about Andrew be the model so everybody else can take notes? I'm just trying to, hey, Julie, just check to make sure he's in the video camera. Okay, so I want you guys to do me versus Andrew, okay? Particularly for the eye things that are going on, okay? So, Marissa, do his eye movements. Get down low so the video camera can see what you're doing.
Okay, so the up
You
down
can't
or
see
just
it.
Where?
watching?
You can't see Andrew.
Her head's in the way? So that's why you gotta get way low. Yeah,
So
good? Okay.
up down,
Yeah, but Andrew, look straight ahead.
follow
Okay.
the light.
Mm-hmm.
Okay, so follow the light up, down, side.
And y'all can come around as long as you're not in the camera.
Okay.
Did he do okay?
Yeah, you did. You tried.
Okay, so you come, no, let somebody else do me. Okay, and do the same thing, get low, so. Get low, isn't that a song? Who sings that? Get low.
Marissa.
Move your big hand. All right.
Up. Down. Side.
Okay, so did you notice anything? Y'all can come close. Come close. Don't shy. I know, they're afraid. You can diagnose me. You can diagnose me. Get way low so the friends can see.
Up. Down. Side. Side.
Okay.
Sorry.
I mean, solid, but
What did you see was different from him?
Your right side didn't, you didn't,
you can go
your right eye
up.
didn't go.
Okay,
Your
I didn't go up.
Your pupils didn't shrink. Like
They did not shrink, yes. Very good observation. Do it again so everybody can see. Go slow. We do him. You do him. Because you're going to have normal to compare to abnormal.
Okay, ready?
Ready.
Am I on the light?
Okay.
Up, down, side, side.
Okay. Make him raise his eyebrows.
Go ahead.
Raise your eyebrows.
Okay, now make me raise my
Can you raise
eyebrows.
your eyebrows?
Okay? Make him puff your cheeks out, Andrew. And then go like this to him. No. Now you do
Okay,
me.
puff your cheeks.
Okay? Differences in either movement you're seeing. That's 5th and 7th, right?
She
did, but you didn't have any
But,
resistant.
so I couldn't take much resistance. So it's not absent, it's just kind of weaker. What about the eyebrows?
You got your whole neck into it.
Okay? So when you see associated reactions, he can just raise his eyebrows and go, oh, but I have to get the whole head in and do a little turkey neck or whatever, right? Okay? Because something is weak in this musculature, okay? Is this normal 55-year-old behavior? Is it just because he's 25, and I'm 55? I could be your mother. I don't feel it like I feel like I'm your same age. I know, you're so sweet.
I don't think, I mean,
I don't
oh, good.
What about the eyes not, did you do his? Did his pupils constrict? And they, you know, they should come back after the light goes away. What did you see about mine?
They stayed
That kind of just didn't
dilated.
go up and down.
Right.
And I will tell you from a functional point of view, and I think I told you last class period, when I walk into movies, oh my God, I'm like grabbing the kids or my husband going, slow down, don't walk so fast, I can't find you. I'm like, I hate going to the movies because of that. Because I don't have light-dark adaptation, okay?
What's that from?
Well, what do you think? It's
Maybe
your
your-
job
your-
to find
your-
out.
I didn't see it
Pupils
happening.
dilated.
Um,
Okay, so write down my symptoms here. What cranial nerves in Mary are not working well? What did I tell you about one? Verbally. Olfactory is overactive, right? You put plus, 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 right? 2, which is optic, okay? I've given you a couple functional things that are wrong with it, and some of you saw pupil constriction dilation is impaired. It's normal in him. 3, what was my problem tracking up, down, left, right?
You didn't go up.
Yeah, or it was delayed, or you saw like associated reactions. So, what elevates the eyelids? Oculomotor. Andrew, open your eyes really big. Yeah, okay, do you see him? All right, this is me right now. I think my eyes are open super wide. Are they? They're not. My eyelids don't open. So 3 is impaired. Maybe it's the nerve, maybe it's the muscles. We don't know. You don't know. I kind of know, but you don't know.
So you said 1 is overactive, 3 is impaired.
Right, 2 is impaired too because I don't open and close, right?
The pupils.
I also told you I had light-dark problems. Driving at night is crazy. You probably don't want to be around my car at night, okay? I try not to drive at night. What I see in street lights and lights, I see overlapping halos, if you will. Sometimes with reading too, like, you know, like the letters overlap. You know shadow font? If you do shadow font, that's pretty much the way I read. So, what I do to try to correct that is I close one eye. And then that kind of helps. So, when I read on my Kindle, pretty much every morning, I take my glasses off and I do one eye, and then after a few minutes I do the other eye so I don't, you know, favor one eye. Okay? What happened when I went in and down to my nose? Did that one seem okay? Because that's 4. You want to do it again?
Yeah.
Okay. And what you may want to do, let me see your pen, little Amy, right there. Okay. Is take the silver part of the pen, get down low so everybody can see. Let's get your exercise in. And you kind of hold it about a foot or 18 inches from a person. And you go left, right, up, down, and then in toward the nose. Okay. So do it again so people can see. Get low so Miss Amy can see. Go ahead. So it's not really going to the right. Kind of went a little to the left. Did my eyes go in?
A little bit.
Okay, just not much though. Probably his went more.
Right.
So this is not absent, it's impaired. Okay? But it's not normal. Okay? He's normal, kind of. His eye movements are normal. I'll just put it that way. Okay? So 3, 4, 5. Well, we haven't talked about 5, but the fact that I was a little weaker in this facial muscle strength and my eyelids don't lift, right? 3, 4, 5, 6, 7, kind of a little bit impaired. But from a sensory point of view, I'm normal. Okay, maybe even hyper-responsive, sensory-wise. So that's a really important piece of data here. Is sensory-wise, I'm over-responsive. So, you know, if you touch my face, like if there's an eyelash on my face, I'll be like crazy until it's gone. So, you know, I feel sensation on my face.
Is that because it's, I don't know if it's compensating, or is it just like that it's stronger because of the weaker motor?
Or it's not a nerve. It might not be a cranial nerve problem. What causes the motor response? Go ahead, Kelly.
Muscle?
Amen, sister. So maybe this is a muscle problem and not a nerve problem. Does that make sense? Okay? And we can explain why and how in a few minutes. But, okay, so glossopharyngeal, what should you check? Are we on 8? 8 is vestibulocochlear. I can hear fine. I do have some balance problems. So if you had me stand and close my eyes, I'm gonna waver like that. Okay? And that was legit, I wasn't faking. Close my eyes, and I kind of start swaying. So again, do I fall? Not often. But really falling, I don't know if Kathy's talked yet about falls in her class, but falling more than once a year is considered a problem. And I probably fall 12 times a year, on average once a month. So people shouldn't be falling that much, okay? So, but I don't know that's because it's a vestibulocochlear problem, right? There may be other reasons why people fall. Okay? So, we have 8, 9 is, right? Tom?
That's okay.
Yeah. So, I kind of sometimes have to swallow more than once to get stuff down. Like, I have to work a little harder for it. But again, not a cranial nerve problem necessarily, maybe a muscle problem. Okay? That's 8, 9. We talked about vestibulocochlear, right? 10, vagus. I have something called dysautonomia. Dysautonomia. Which might be a dysfunction in the vagus nerve. What might dysautonomia be without even knowing what it is?
Your body has problems regulating itself
Okay, in what way?
in your like basic breast and digest type function, like autonomic.
Okay, so give me an example. What would the symptoms be?
Maybe digestive.
Maybe digestive, although I don't have too many digestive problems.
What about like body temperature and blood pressure?
Amen, sister. So I have really low heart rate. My blood pressure over the years has gone up a little bit, probably to compensate for my low heart rate, which like is usually, and I'm not a fitness, junkie like you, but, sometimes it's in the 50s. Okay? The only normal people whose heart rate is in the 50s are marathon runners. Okay? I'm not a marathon runner. So, but to have a resting heart rate of like 58 to 60, that's something ain't right there. Although, the doctors just think I'm crazy. Yeah.
Does that make you prone to fainting?
Yeah.
Okay.
And I don't like pass out like, oh, I got the papers. I just like, whoa, I think I need to sit down.
Okay.
Kind of thing. Okay? So southern.
Because my mom and my sister are both prone to like
swooning a little bit, and my mom had a what's it called, catheterization for AFib, and when the doctor went in, her heart did something that he referred to as like a vagal reflex, where it
vagal
stopped
response, yeah.
instead of
Yeah, yeah.
sped up. So that,
And so I take medicine for dysautonomia. So the other thing that dysautonomia, which again, you don't know is it thyroid or is it dysautonomia, is the whole temperature thing. I'll be like all hot and all cold, and I thought it was like menopause, and it's not, and it's like, oh my God. And often when I break out sweating, it's related to the dysautonomia. So the heart rate is just fluctuating and my body isn't compensating for it.
Is it just at any time, or is there like something that you
Now,
should-
you know, sometimes I try to say, like initially, I'll sort of give you my history, well, it's a long history, but when I was diagnosed with dysautonomia, it was like a Sunday, my husband was going out of town for work, and I said, honey, I don't think you should go out of town because I think I have diabetes. Like he looked at me like, crazy. And so we went to like a urgent care, and my heart rate was in the 40s. And I was like all diaphoretic. Do people know what diaphoresis means? Where like you're sweating, usually on the top of your lip, and it's like, oh, and it could be because you have low blood sugar that you're diaphoretic. So diaphoretic, your heart, like your pulse is racing, but your heart rate is really slow. It's like a strain, and then your body's sweating, and it's like, oh God, my body is just like freaking out right now. And so they're like, we think you need to go over to the emergency room. So I go over to the emergency room, and you know, my heart rate is still in the 40s over there. And they didn't do anything for me. They're like, well, I guess you should see a cardiologist. That's it? Okay. So I said to my husband, well, so-and-so will be around, just go out of town. And he went out of town, and then I saw a cardiologist pretty quickly who said, oh yeah, you need a tilt table test, which was the most horrible experience in my life. They put you on like a table, and they give you some kind of drug while you're there, and then they gradually like elevate you until you pass out. I was like, whoa! I was screaming. Yeah, and here the doctor goes, yep, you have dysautonomia. Here's a prescription. See you in a year. It's like, that's it? That's it? What? So why might somebody have dysautonomia? It just doesn't come like just because, I mean, isn't there, that's a symptom of something else, right? So we're through my cranial nerves, right? 12, look, I can do this, right? This is, 11, right, accessory? I can do this, so, you know, might be a little weaker than him, as you see, but I'm okay. All right, so what do you think? Diagnosis. What? What diagnosis might affect muscle function? What'd you say? You got an answer?
No, I asked if you're able to move your tongue, and then he said you have to swallow more often. So then there's
Tongue, I can move it.
But then you have to.
I kind of have to have a little associated reaction thing, so slightly weak. But I will tell you, a neurologist will classify me as normal. So I've been to, I don't know how many doctors. I have a notebook that I carry with me, and they just think I'm a wackadoodle, but you know, I am. So I went to Emory, went to a clinic. I won't say which one because I don't want to give it away. You know, the doctor was like, well, you're within normal limits. And he had like 5 medical students with me. I said, wait a minute here. Test them and test me and tell me that I'm friggin' normal. I am not. I am not. I am like a strength of 3 or 4 out of 5. I'm not 5 out of 5. And they like looked at me like, you're just expecting too much. I was like, I'm 55, I'm not 85, right? I should have normal strength, right? I don't. It's like a maybe 4 out of 5. Depends on the day, sometimes 3 plus, okay? It's more than a 3 because I can take some resistance. You remember your muscle grades, people? All right, what else? So, when you check my sensation, I'm normal. So, remember, function or motor function is based on sensation and the efferent stuff, right? So, incoming is fine for the most part. Outgoing is a problem. So, if it's a motor problem, what controls muscles? Come on, where's my exercise science people in the room?
Well, isn't the like the neurotransmitter?
Good, okay, so keep going with that.
Your body's not producing
You said a word a
acetylcholine.
minute ago. Acetylcholine could be a possibility. So it could be biochemical, right? So what disease might be associated with acetylcholine? Because this is the process I went through. This is the first testing I went through. So I go to this physician just for a physical. And she said, have you ever had that eyelid droop checked out? I don't know if you can see, my left eye is a little more droopy than my right. She said, have you ever had that checked out? And I was like, funny you should mention it. About 5 years ago, I went for glamour shots, and my eyelid was droopy in the picture, and so I made them redo the glamour shots because I was like, I didn't look beautiful. And they redid it, and the eye droop was still there. And that same year, it was around 90. This has been going on for 20 plus years, so it's not, I'm not going to die or anything. Don't worry about that. In the middle of your semester. That's why I tape every lecture in case I die in the middle of the semester. Then you won't be without a teacher. So that same year I did the glamour shots. This was about 94 or something. I went home for Thanksgiving, and my brother, who is as blunt as I am, looked at me and said, "What's wrong with your eye?" And I was like, "What are you talking about?" He was like, "That left eye is completely droopy." And I was like, "Well, I'm writing a master's thesis. I'm doing a lot of computer work. It's just that." And that was the same time period I did the glamour shots, and I didn't think anything of it. 1996, I had a good physician who happened to be a physical therapist before she was a physician. So she's really in tune to motor stuff. And she said, "Have you ever had that eyelid checked out?" And I said, "No." And she said, "I want to send you to a neurologist," who proceeded to test my acetylcholine. Why? What would an acetylcholine deficiency, what is a diagnosis? Look it up.
MG.
What?
MG.
MG, which is? Good
I can't
girl.
remember the M. Gravis.
Myasthenia gravis. So that's the first thing they look for. Eyelid droop is a hallmark symptom of myasthenia gravis. So they give you a drug called tensilon that stimulates your acetylcholine receptors. And if you overreact to it or underreact, then you would be diagnosed with myasthenia gravis. Well, I had no reaction, so I don't have myasthenia gravis. So that's the doctor's decision tree. A typical neurologist will go for the most obvious thing first, right? So he said, this neurologist, I really would like for you to go for an MRI. Well, in the interim, I realized that I was pregnant with one of the kids. I can't remember which, I think it was Hannah. At this point it was like 1997 or something, or 98. And she said, or the doc said, "I want you to get an MRI." So I scheduled it and then realized I was pregnant. And I was like, this isn't causing that much grief. I don't want to expose a baby to radiation that doesn't need to be exposed to. So I never followed up on it for a number of years. So fast forward, this is 98, fast forward to around 2000. I had this other doctor I liked, and I kept going back to him and going, I've lost my groove. And I'm not depressed, because a lot of doctors would go, well, you're just depressed. No, I'm not depressed. I'm telling you, I'm not depressed. So, just like hot, cold all the time, and the doctor's like, well, maybe you're perimenopausal, take some soy. I was like, that's not working. And then, fast forward, so I'm like, just like kind of ill, kind of like droopy, and just don't have energy. All the while, I still swim, walk, it's not like I can't exercise at all, but it's a maintenance dose of exercise. Not doing marathons, swimming half a mile 3 times a week, and just like maybe walking on the treadmill, maybe a little bit of weights, but nothing. It's really a maintenance dose, So it's not that I can't exercise. So anyway, mother-in-law moves in with us, talk about chronic disease there. And she lived in the basement. And I would like smell her food in the basement. And what the hell's that? This crazy woman. Anyway, my husband just said, you are friggin' crazy. I was like, yes, I am. And I was like, but I keep going to physicians and they keep telling me nothing's wrong with me. And so I said, fine, I'll go see a shrink. And I go see a psychologist who says, I want you to read this book. And somebody in here is reading it, The Edge Effect. Somebody in here, well, it might be somebody who's on the cam. Anyway, I read that book, and he turned me on to this other book called, I think it's called Life Extension Revolution. And this whole premise of the book is just amazing, that, like you have lab values for your thyroid and for these other chemicals. And the lab companies or your insurance only pays for lab values that are clearly clinical diagnoses. But you and I could feel symptoms and be, still in the normal range. Well, what I came to find out from this book called Life Extension Revolution was that it's sort of like a conspiracy on the part of the insurance companies. This is just my politics here. I'm all about conspiracy. Anyway, let me just take thyroid, because a normal thyroid, insurance companies won't pay for thyroid medication in general by a general physician if your thyroid is like 5-something or whatever. It has to go, like a higher thyroid is worse, I forget. I don't know. But anyway, like insurance companies pay at a certain value. In this book, clearly there was like study upon study that if your thyroid is not below a 2, you're probably hypothyroid. I was like, wait a minute, but insurance companies won't pay for your drug until it's 5-something. So what happens to people between 2 and 5? So I went back through my medical records for all these previous years when I was like the hypochondriac going to the doctor, and I created a spreadsheet, And I showed my doctor my thyroid is going up, but it's still in the normal range, right? So I bring it to an endocrinologist, and he was like, why haven't you been here 5-10 years ago? So you have hypothyroidism really badly. I was like, wait, I got an excuse for being fat. Yay, good. Anyway, so definitely was diagnosed with hypothyroidism. Well, hypothyroidism is also associated with eye drooping. Who knew? Who knew this? But, so it's like, okay, great, I got hypothyroidism, I'll go on medication, and I'm on this medication, and it certainly helps. But fast forward, you know, like even 5 years of being on hypothyroid medicine, I still got eye muscle problems that are getting worse, hand strength problem, all the muscle stuff isn't getting better after 5 years on hypothyroid medicine. And so I went to this ENT because I was having balance problems and falling, and the ENT ordered these balance tests and all these inner ear tests, and he said, you know, I'm not so much concerned about your balance, but this eyelid droop bothers me. So it's funny, certain physicians hone in on certain things, and he said, I think you need to get that checked out. And I had been going to an ophthalmologist every year, and he alluded, if you want to get that eye fixed, I can send you to Emory for it. And I was like, well, what's wrong with it? I was checked for myasthenia gravis, I don't have it. He was like, I don't know, but if it's in your visual field, you know, get it checked out. So anyway, eventually I go to Emory, and they're going to do an eyelid lift, right? Which I've had 2 of them, believe it or not, and I still have these droopy eyes. And so y'all can feel them at break if you want. I have 3 slings in my eyes, so that it's like middle, here, here. So like right now I can't open my eyes, but watch this. I can open them when I move my head back. So the slings work if my head is like this. So if you see me driving, that's the reason why. So the doctor, before he did the first eyelid lift, said, because it really was in my visual field, they won't do anything about a droop until it's covering like half of your pupil. And so he said, well, let's figure out why you have this condition. So he sent me to the neuromuscular clinic, and eventually I was diagnosed with something called CPEO. CPEO. Chronic Progressive External Ophthalmoplegia. CPEO, chronic progressive external, meaning your eyes can't go side to side, external ophthalmoplegia. Plegia means paralysis, eyes, ophthalmo. Okay, chronic progressive ophthalmoplegia. It is a mitochondrial disorder. I have had a muscle biopsy that confirmed you have red ragged fibers. That is a symptom of a mitochondrial disorder. The doctor calls me after this muscle biopsy on the phone, says, yeah, you have CPEO, you have red ragged fibers, just get a EKG every year. Like, that's it? Really? That's it? Yeah, there's no treatment. It's like, come on, there's got to be some treatment for this. Nope, no treatment. I was like, wait a minute here, this isn't fair, you know? So, so then fast forward, that was like 2005, 6. Fast forward to about 2011, and that's when the dysautonomia started. And that's more disheartening, because if you pass out, you know what I mean, or you know, your heart isn't right. I was noticing, like, I would have to lay in bed at 8:30 every night, kind of like I had to recline a lot. And that's part of the dysautonomia, which I still do pretty much, you know. Once I get home, I'm in a reclining position. So people could have a lot of energy, you know what I mean, but not have muscle energy. So I'm really telling you about my situation because it's all about me after all, but is that people could have chronic disease but not necessarily be disabled. Does that make sense? So I take a drug called proamine, Notice it has amine at the end of the name. And Proamine kind of works, you know. So I'm like, that's it. That's it. That's all I got. And I had worked with kids with mitochondrial disorders. And I was like, wait a minute. My kids with mitochondrial disorders take cocktails. I was like, I like cocktails. So I knew they had taken something called a mito cocktail, M-I-T-O, like mitochondrial cocktail. I didn't know what was in it, but so I go to a local neurologist and I said, you know, I've been doing some reading on mitochondrial disorders, and you know, of course I bring my white notebook in and she's like, oh boy, here comes a big hypochondriac, you know. And I'm just wondering if you know anything about mito cocktails. She goes, way out of my league. No, yeah, you gotta go to blah, blah, blah. Refers me to this guy at Columbia who isn't taking new patients anymore. There's only like 5 doctors in the US that are considered mito specialists. I'm like, really? The next one is like in San Diego or in Ohio at the Cleveland Clinic. I was like, I don't like Ohio. I'm not going there, you know. So online, I'm just searching mito cocktails. And I find the lady locally who's a geneticist, who is a concierge physician. You pay money. She doesn't want to deal with insurances because she's fed up with insurance. So I go to her and she goes, why are you not on a mito cocktail? I was like, tell me about it. And right then prescribes the mito cocktail, and my life has changed. I mean, I'm not completely where I need to be, but so I take a mito cocktail every day. I take 800 milligrams of CoQ10, 500 milligrams of carnitine, 500 milligrams of creatine, riboflavin, and one more is in the cocktail. So like I take a cup of supplements pretty much every morning.
But are any of those actual prescriptive, the ones that I've heard you list, are stuff you can get?
No, right.
Sure.
So I go to a compounding, you know, there's people who are called compounding pharmacists, and it would have been like $1,000 a month out of pocket. And you know, they would make like a compound where they would compound all these supplements down to 1 or 2 pills. And the pharmacist, the compounder, who was president of the Compounding Society in Georgia, so I kind of trusted him. He's actually up here in Gainesville. Said, just go buy the supplements over the counter. What's the big deal? So I buy my supplements. They're called like pharmaceutical grade supplements. So they're not like where you buy them at Walmart. They're like, they have a little more of a seal of approval, if you will. Anyway, so I take like really literally a cup full, and like a lot of mornings I gag on them. It's, you know, but what's the alternative? And it's a lot cheaper, but I still spend, oh, it's not that much. It might be $300 to $400 every few months. So it's still a lot cheaper.
But could that be related to like a nutrition deficiency that you're taking these supplements, or is it something else?
Well, if your mitochondria are not working, right, they're the powerhouse of the cell. I have looked into diet too, okay? And I'm not there yet. I need to be like Andrew, who eats like a bowl of meatloaf and nothing else, right? Because that's like high protein diet would actually be good for me, you know? But, and I've looked into something called the WAHLS protocol, W-A-H-L-S. This woman had MS. And she feels like she cured herself with, I wouldn't say cured herself, but really ameliorated the effects of MS with diet. And it's kind of like paleo kind of diet. Anyway, I tell you this because these are the kind of patients you're going to be working with. Chronic disease patients are unhappy with the medical system because unless I'm acutely clinical or in a wheelchair or really disabled, they're not going to do anything about me. I'm pretty functional, right? So I'm this in-between kind of patient that they don't like, that I'm crazy, okay? And I admit I'm crazy. You know, I'm not negating that. But I know my body and I know when I don't feel good. The reason I tell you about this too is because if you work with children with like a mitochondrial disorder, these parents are just searching for any answer. They are going to try all wackadoodle diets. They're going to try supplements. They are going to try whatever will enhance their child's quality of life better. And so don't fully fall into the trap of, unless it's medical model, it is bad kind of thing. So you want to help people by supporting them with the evidence, particularly if something is contraindicated. You want to help alert your family to, hey, here's a paper, judge for yourself, right? So people with MS, patients with MS, adults with muscular dystrophy, kids with autism and muscular dystrophy, or, you know, there's all kinds of weird mitochondrial disorders out there. You know, when I heard mitochondrial disorder, a lot of the kids that I had worked with died. And so I was like, oh my God, mitochondrial disorder, oh my God, I'm gonna die, blah, blah. So there's different, adults with mito are a little bit different. And usually it's more like my picture, like a chronic disease that you need to manage kind of thing. Does that make sense? So other questions? And if you were treating me, what would your intervention look like?
So like things that you enjoy doing but would address any kind of impairments you may have. So if you already like swimming, maybe it's hydrotherapy based exercises and things like that so that you can identify with it but still adjusting the strength, taking the weight off the joints but still accomplishing the goal. Mm-hmm.
Well, I don't have a joint problem. Weight, actually what the geneticist said is exercising is the best thing for you. Caffeine is the best thing for you. Yay! Because caffeine elevates your heart rate, right? So that's a good thing. So I was like, alrighty. I have every morning 2 cups of coffee, well, 1 or 2 before I get out of bed. Sweetie brings me coffee every morning. So nice. I'm gonna keep them just because of that. You know what I'm saying? But it takes me a long time to get up in the morning. Like I have to be almost 3/4 through that cup of coffee before I feel like I'm movable. And I used to be able to like jump out of bed and move when I was younger. So, and I don't think it's an aging thing. So that's the other complication with people with chronic disease. I still believe I have the same condition that my father had. And there's a myth that mitochondrial disorders are all passed down through their mother. I have the same eye droop that my dad had. I just have so many symptoms that my dad had. And they're like, no, moms pass on mitochondrial disorders, and that's not accurate. So, but I think my dad was never diagnosed.
And yours is also confounded by the fact that you're a woman, so they're like, oh, it's perimenopause.
Yep, and hypothyroidism.
Mm-hmm.
And some of the same symptoms of weakness, eye droop, lack of energy are all part of hypothyroidism. So what's, you know, this chicken egg stuff going on here?
So as far as intervention,
Typically you wouldn't see me unless I would be in a wheelchair or you were working in some wellness kind of center.
as far as interventions go, I mean, if you were at the point where you were disabled or having issues functioning in life, would it be working on like you said, you take a cocktail in the morning and you have to have your caffeine and all of that. Would it almost be developing a routine so that you can manage your manage your medical issues?
Yeah,
so that then
like the Proamidine, I'm supposed to take it 3 times a day. Do I ever take it the other 2 times a day? The Mitococktail, I'm supposed to spread out through the day. Well, I know once I get to work, I'm too busy. So I've just accepted the fact in the afternoon I'm going to be weaker, and so I like 8 o'clock classes because I'm better in the morning because I've had my cocktail, you know? So, you know, I've sort of worked it out with my work and that kind of thing, but if I went to work somewhere else, I might have to adjust my cocktail if they make me teach in the afternoons, right? So definitely schedule, medication management, maybe I spread those supplements out. Because maybe I'm wasting some of my money by taking them all in the morning, right? Because I metabolize them. I sound like I'm from not Chicago, but you know, Minnesota or something. And then, you know, maybe I'm peeing out half of what I really should be having at 12 o'clock noon. Does that make sense? So this is important to work with your patients, not that you're a physician or a pharmacist, but on medication and when are you supposed to take it. And you might want to go back to your doctor and be realistic. Like I'll say to my doctor, prescribe it for 3 times a day, but I'll be lucky to take it once a day.
Right.
My recent event, this is a new thing. In the last year, I've been numb down my arms. I'm like, oh crap, maybe they misdiagnosed me. See, my crazy person that I am. Oh, I probably have MS. You know, having a little medical knowledge is a dangerous thing, okay? Because you're going to self-diagnose. But I have numbness here, all through here, okay? And when I say numbness, it's not absent, it's tingling. And it's kind of here, and then here, and then I have 2 patches in the inner part of my leg, and like near my knee. And so, of course, I go to the doctor, and I go to the urgent care, because it was like scaring the crap out of me. I'm like, I'm having a stroke! And I did, like, I kind of magnified it, so they would order an MRI before I went to the neurologist. Because you don't want to waste your time going to a neurologist, and then they order an MRI that takes 2 months to get. You know my situation here, right? I know how to play the system. So I go to the urgent care and I act like a crazy woman. I'm having a stroke. At least I need an MRI. So they order an MRI. Then I make a neurologist appointment, which takes like 3 months to get a friggin' neurologist appointment. I'm like, what if I really was having a stroke, you know? And I bring the MRI to the neurologist so I'm prepared when I go in. Well, you have a little stenosis in your neck and a little bone spur, and that should not be causing the numbness and tingling. I'm like, and? Okay, well, let's do a nerve conduction study. And so they said a nerve conduction study, I think they said an EMG. So EMGs, they just put electrodes on your muscles and they check whether your muscles are responding. Oh, I could live with that. Nerve conduction study, they shock you. And I say, and I'm like, every time they did it. And I was like, you didn't tell me it was this. I've had like 5 of those before too, you know? And anyway, so the doctor, again, doctors, the system is broken. Okay, that's all I'm saying. You're entering a broken system. It's still a good system, but it's a broken system. And he says to me in the hallway, well, you have a normal nerve conduction study in the hallway. That's it? So go ahead, pat my head and tell me to go home. Well, what do you want me to do? That's on tape. So, you know, he was like, well, do you want another referral? do you want a second opinion? I'll send you to another doctor. I was like, is that doctor going to get any different results? I'm 55 years old. I should not be numb down my arms. Well, here's a prescription for gabapentin. But that's it. So this is where I'm at this point. And I will admit, I'm sorry, the reason I thought I was having a stroke, this is another piece. People will tell you their history in all this piecemeal way. And you'll be like, why didn't you tell me that in the beginning of the story? So I'm laying in bed, and every time I turned my head laying in bed, I would have this vascular pain all the way up. And of course I know the arteries. So I'm like, oh my God, my middle cerebral artery is having a stroke, right? So that plus the numbness down my arm was like, oh my God, I'm having a stroke. You know, and I would roll over. I told my husband, and who's a nurse, okay? My husband's a nurse. So I'd be like, honey, I'm having a stroke. And then he has like vascular pain too. And he was like, no, I'm having a stroke. So we're having a competition to see who's having the bigger stroke. Anyway, so the doctor, even before the EMG, when the first visit, you know, is prescribed gabapentin. And I must admit, the gabapentin completely helped the vascular pain. I still have the numbness, but at least I'm not scared by the fact that I'm having the stroke. But again, it's not treating the source of the problem, it's treating the symptom, which is vascular pain. Does that make sense? So again, he prescribed gabapentin 3 times a day, but I only take it at night because that was the only time I was really having this scary pain. Does that make sense? Mm-hmm. What are you thinking, Julie?
I don't know.
You think I have a brain tumor. Thank you.
Yes, that's exactly my medical diagnosis. I don't know.
What are you thinking?
Well, I mean, if you prescribed it 3 times a day, maybe you do need it continually in your system in order to even have it reach down into your arms.
Mm-hmm.
But then on top of that, would you ever consider trying to go to a chiropractor and see if maybe something is
I see a chiropractor.
and that hasn't helped at all with the numbness.
No.
And what was the chiropractor's opinion? They're stumped as well?
She kind of treats me orthopedically,
Okay.
you know, and I've had like low back pain forever. Mm-hmm. Oh, she did do this, and this is the one thing that I was amazed at the neurologist, like, wouldn't you send me to physical therapy? If someone has numbness down their arms, right, and they have a little stenosis, and they have head forward, wouldn't you at least refer me to a physical therapist for postural training or kinesiotaping or cervical traction maybe? Right? I mean, duh. So I did start, I had already been seeing the chiropractor for low back pain and neck pain, right? That's orthopedic. And I said to her, you know, like, do you do traction? And she hooked me up with the TENS unit, a cervical collar that you do a little, you know, they used to do cervical traction over the door, which was a little confining because then you're stuck to a door for 20 minutes, you know, a day. And that's like not realistic. I need to do stuff. But the cervical collar is kind of cool. It's, you know, it looks like a regular cervical collar, but it has a thing on it that stretches your neck. And like just that plus the TENS unit and a back brace and a like it's like cervical traction. It's like you lay on it. I've only used it once, and it has a neck thing that kind of pushes your neck, like stretches you out. And that's a little confining, so I haven't used that. But the TENS unit, and you know, that stuff does help. But I kind of don't use it until I really notice that I'm sort of dysfunctional. But she is the only one who did, and a pillow, a better bed pillow. Mm-hmm. Who knew? And it's sort of hollowed out in the middle. My husband was like, "Oh, I like your pillow." It's like, maybe Santa Claus will bring you one. So does that make sense? So yeah, I feel like at least she kind of addressed it. But I had to kind of ask, You know what I mean? And the physician was like, oh, physical therapy won't help you. Really? I think physical therapy would have helped me. Like, especially posturally. But, you know. So, there are some, but again, am I consistent? And where there's a brace that I wear sometimes when I'm really kind of in this sort of thing. And it just puts me more upright in a better posture. But it's kind of confining, to be honest, you know. So I really don't wear it that much.
And you don't like weight training to kind of tighten everything up? I mean, that's
Look at
more
her.
for you. I don't know if you would have the answer. Do you like that or no?
I do weights once a week. I don't love it.
You know, there's actually a physical therapist. I'm training to teach bar, and it helped me with back problems.
What's bar?
Bar is like Pilates meets yoga meets ballet meets. A physical therapist owns this particular company. So she put a lot of neuromuscular in there, but she actually has another physical therapist from town referring her people to take bar for actual postural issues and things like that, because it strengthens like your powerhouse muscles, aka
Right.
core,
Right,
thighs, whatever. But I think it's amazing for posture.
Right.
You're just so much the awareness so that you can self-correct.
Right, yeah. But the point is that, like, people's problems are way more complicated, right? So definitely I have a core muscle problem, right? I have a lifelong postural problem. I have, you know, really a true cellular problem, right? And a biochemical problem when you think of the hypothyroidism on top of it. So, you know, like, people are way more complicated than the diagnosis you're treating them for. So if I came to you, it probably would be for the mitochondrial diagnosis, which will probably get you the best reimbursement. Do you know what I'm saying? You wouldn't get reimbursed to treat me for hypothyroidism. Does that make sense? So I just want you to really think about this when you work with your patients and their families. And I would advise you from a patient education point of view, particularly with anybody you work with chronic disease, even though the docs will think they're wacky, make them keep a notebook. I keep all my lab values, I keep all my super bills, you know, like, so a physician can say, oh, you were treated here, and these lab tests were ordered. Where's the results of that, Mary? A good physician will do that, you know? And it's hard to find one that, unfortunately, in the broken system, they're only reimbursed for about an 8-minute encounter. So to find one that takes time with you is few and far between.
Could your numbness be from maybe like a pinched nerve though? Because I had an embarrassing fall, and I had a pinched nerve like somewhere up here, but I had like tingling in my arm as well.
So yeah, it could be. I think it's postural.
Okay.
I think it's this and the fact that I have larger breasts and everything's here. And you're aging, you know what I mean? So everything's coming forward and you got a little stenosis there that's narrowing of the spinal canal and a little bone spur, even though the doctor said that shouldn't affect it. So I got a bone spur, stenosis, a lifelong habit of posture. I'm all rounded here, right? And it's both arms. So that tells me it's the neck.
Okay.
It's not one arm, you know what I mean?
Right.
So both arms, it's the canal.
But could it also be like vitamin or electrolyte insufficiencies? Like if you don't have enough potassium, you will get numbness down your leg?
Yes, and you don't have good nerve conduction, so it could be nutritional too. Yeah. In fact, the last time I went to this geneticist, she prescribed something called leucovorin. Write this one down. It cost $1,000.
What's it called?
$1,000 friggin' dollars. Leukovorin. Leucovorin.
Lost me.
Leuk, right? That's a cellular word, like leukocytes.
It says it's a chemotherapy.
I know. And it's for people with significant deficiencies in calcium. I tried it twice, and I got so sick from it, I was like, this is not worth $1,000. And I just emailed her and said, by the way, I'm not taking that drug. You know what I mean? Really?
What was the end of it?
Vorin, V-O-R-I-N. Leucovorin. And it is a chemotherapy drug, and when I saw it, I was like, really?
But I think my grandma.
All right, so comments about neuro exam, chronic neuro patients. You're all gonna try to treat me now. Yeah, Josh.
Oh, you said about the neuro exam? Oh, I'm sorry.
Not the neuro test, the neuro exam that a doctor does. Okay, yes ma'am.
Do you feel if, you know, fast forward 20 years, you're just now getting it, that you would have come to this answer a lot quicker than instead of it taking you 20-some years?
Well, look at me, I have some knowledge. What about people who don't? Right? And anybody who's read the history of Oliver Sacks, who just passed away a few weeks ago, he was interviewed by Terry Gross, and she said on public radio, and she said, I find it interesting that you have all these neurological conditions. And he said, because I have knowledge about it. And so I get my friends to diagnose me. He said, a lot of people have neurological impairments, but they just accept it and adapt to it, and they never get a diagnosis. You know what I mean? So I feel like because I push the system, I would never have had this diagnosis if I just said, like my dad, who I still believe I am incarnate him in his body. Same symptoms, same everything. He got to be around 83, could no longer grip utensils, right? And he goes to a neurologist and he's like, well, you're old. I'm like, bullshit. 85-year-old people should still be able to grab their utensil to feed themselves. Really? It's like, well, you got a little stenosis in your spinal column. I was like, okay, you're not worth the degree you're written on, you know?
How long was he that severe before he finally passed?
I don't know, you know, like he started falling, all this stuff is real gradual. I would say 30 years, do you know what I mean? So again, but he also had diabetes, he also had like heart disease, you know what I'm saying? So what causes what, right? Does that make sense? So a lot of the people you're going to work with are these mess of chronic diseases that overlap with each other. And they're on all these medications that overlap with each other. You know, you don't want to question it in front of the patient, but you may want to look up, why are they on that and that for this? But what happens is you go to these different doctors, they all prescribe different medicines, and poor doctors, they think when you come there that you want to leave with the prescription, right? And I don't. I'm often seeking answers, and it may not be medicine, but they think that's the way they're trained, unfortunately. And a lot of doctors are throwing their hands up and saying, no more. I'm doing concierge, cash pay only, because then I can practice medicine the way I want to practice. And I know several physicians that that's all they do now.
And is it affordable to go that route?
No, you got to be upper middle class or rich to go see them. But the physician feels like they're providing quality of care. Now,
Do you feel like if there's
until we
enough
change
of
the
them-
system, that's, you know, not going to happen.
Do you feel like if there's enough of the doctors that are changing this movement or like making this
I
decision
hope
that
so.
maybe it'll-
I hope so, right? And that they lobby for insurance to cover better quality of care.
But don't you think even more of that, it starts at the pharmaceutical route? You have so
Oh,
much
well,
money, and they're the
There's
ones
a
that are
great movie about the
pushing all
VA called Something on Fire. And it's not VA on fire, but it's medicine on fire or something like this, and they track, it's like, oh my God, this is why the VA, it's not the VA's fault per se, it's that the VA is staffed for taking care of X number of patients, and they got this great influx of people that they're not really staffed for. So the answer was send everybody home with 90 days worth of pills, a bag of pills, and they have the highest addiction rates of any medical system in the universe.
Don't also the doctors get paid less to be there, so you have less quality physicians because you get paid so little?
Yeah, I mean,
It's most of the time volunteer work during residency, I think.
well, they're paid on the residency. You know, and some VAs do really good research. So, you know what I mean? Not all VAs are horrible. The Atlanta VA in particular is not as good. But it's a problem. It's the definite system issue. You know, and all we can do is try to push the system and treat our patients and educate them to advocate for themselves, right? And that's what we need to do. Do you have thoughts about the VA? Do you take care through the VA?
Yes.
Okay. So you don't have a choice?
I don't have a choice.
Okay. If you had a choice?
No, I wouldn't go.
Okay. Yeah. So, and have you had a similar experience? Not
Like you
having
said,
pills?
it takes forever to get any type of results back.
Mm-hmm.
Something simple as a complete blood count
Yeah.
is impossible to get.
Right.
And then, I don't know, it's just, everything's backed up.
Yeah.
Like, I just got a call from the department that deals with pain management,
Yeah.
and that took, you have to wait for them to contact you. You can't be proactive. And it, from the time the doctor put in the notice or the prescription, it took 3 months for them to contact me because they were backdated. So.
Do you have numbness?
Oh, and then they said, come in today at 11. And I said, oh, well, this is too short notice.
I'm in school, yeah.
Yeah, and I'm in school. Like,
Right.
God forbid, it was the day we had class. And I said, what if I can't schedule today? When is the
5 months. Yeah.
They said December.
Yeah.
Yeah, and
It's another broken system. It's, you know, it's unfortunate, but
their pain management they prescribed me took. They have to mail it to you, and it took me 2 months to get it from Atlanta VA. So that just means they were backed up. And I
wow.
don't even know if I would have got it because I had to call them.
Right. It's almost like a full-time job taking care of your medical needs. So you can imagine the parents, your family members that your people work with, it's like they're on the phone all the time. It's like a nightmare. Yeah. And so they're not going to be pleasant people sometimes. You know, they're just going to be happy that you listen to them. I mean, so sometimes that's what you might do for half of the session. I might be doing neuromuscular stuff with Josh, and really what's more important is that I'm listening to him and talking to him and saying, yeah, I'm sorry that it took you that long. You don't like trash the VA, but you just say, wow, that's, you know, I'm sorry you had that situation. And people just need to know that somebody's listening to them, because that sucks. Yeah.
Are you even within your rights? Because if I am working in any system, you have your productivity levels, you have to meet all of these A, B, and C. So you're already limited by time, but then is it even within my rights to say like, hey, by the way, you should maybe look into A, B, and C? When really I'm only here to treat you for what is the main, what we're gonna get reimbursed
I
for.
look for doors when the patient opens it.
Okay.
So if a patient says, you know, I've been thinking about diet, and then you give them resources about that, or you direct them toward the resources so they can find them themselves. But you gotta
Never
be careful,
initiate
you gotta be careful about supplements. You're not a doctor, you're
Right.
not, you know, you don't want to say anything that will contradict their medical treatment, but if they open the door, then you kind of like lead them, well, here's the evidence, here's a website, and let them kind of, you want not to just, you want to be objective though, like pro and con, and let them decide for themselves, or say, you might want to talk to your physician about the medication having all these side effects. Even though you might know there are bad side effects, like the leucovorin. It's like, whoa, I couldn't even, I was so dizzy I couldn't see. So I was like, this is not, there's a cost-benefit ratio of taking that drug for me, for my quality of life. So I just made a conscious decision, I'm not taking it. Does that make sense? Okay. All right. Questions about the exam and how it informs, you know, your eval. The doctors will just write in the chart, they'll write 1 through 12, cranial nerve, and they'll write a 0 if no problem, or impaired, intact, or sometimes they'll write pluses and minuses next to each cranial nerve in the medical record. Or they'll might write CN exam all intact, or CN exam CN3 impaired, all others intact. They'll try to like do it as quick as abbreviated as possible. Okay, so let's take a little break for 5 minutes, and what you're going to do when you get back, I'm going to go over this exam, and then we're going to figure out which cranial nerve are we checking when we do this exam. Okay? All right, Andrew, you know what we could do?